Good afternoon, everybody. I am Vijayanand Jamalpuri, neonatologist at Rainbow Children's Hospital. And thank you, Murki sir, and thank you, IAPTCB, Bhaskar sir, and I can say CN Reddy sir and PV Rao sir. And I know it's always tough and difficult to do a pre-lunch session, which is a little bit delayed. But how can anybody stop people like Rishikesh Thakre or Srinivas Murki sir, who all excellently. But I promise you, I have an excellent panel who will not disappoint us. So I will introduce one by them. They don't need introduction. And I have Dr. Tejo Pratap Voleti, graduated from AIMS, and he has got any introduction. And of course, Dr. Aparna, again, product of AIMS and very passionate about neonatology. And of course, Dr. Sriram, very humble and simple, side says, but you know about him. He's excellent. And of course, our Kalyan Chakravarti, and again did from Premier Institute, one of the Premier Institutes from India. And he is also very passionate about neonatology. So with that introduction, what I'm trying to do is first one slide. You probably several talks. You guys might have seen this paper, which was quoted again and again, and is a paper from Dennis collaboration. Very, very, very concerning data emerged in the 2015, the middle of the last decade. So 82% of the Acinetobacter, the common gram negatives which are in our NICUs are multi-drug resistance. So I'm not going to read all those, not only gram negative, but also gram positives. It's a very concerning data. So it is very important. On one side, we need to use the antibiotics appropriately. And on the other side, first of all, I mean, as Dr. Murki said, we try not to use, prevent the infection. But we know the reality. We know the reality that infection is prevalent everywhere across all the units. So we need to balance that, because we are all worried if the baby comes with fever or not quite right. So we don't want, because the cost is high when you miss it. So you always this dilemma of treat, not to treat. Again, you err towards saving that baby, but there is a lot of disadvantage of overusing. What we try to do in next 30-35 minutes, we'll take a case scenarios, one after the other, and try to give a simple, clear messages. And first, I'll take a case one. A 36-week-old baby boy, 2.6 kilos, born by elective LSCS because of previous LSCS. No, and everything was fine during antenatal period. There was no maternal fever or prolonged rupture of membrane. Early respiratory distress. Blood gas was normal. And this is the X-ray. My question to Dr. Tejo, would you start or should we start antibiotics in this baby? Dr. Tejo.
Yeah, thank you, Dr. Vijayanand. Good afternoon, everyone. Okay, so first thing is that, as Dr. Vijayanand has told, that it is a 36-weeker baby, which is a late preterm and born by LSCS. It was a planned LSCS just because the mother was has given the birth previously to the C-section. So there, why I am again emphasizing these 2 points is that this baby was not having in the fetal stage any risk factors as shown in the previous speaker slides about what are the risk factor strategy and other things like maternal fever and PROM and other things. Second one is it's a late preterm baby. So, and your presentation is only respiratory distress. So in a late preterm baby who is having RD within few hours of birth or few minutes of birth, so first possibility is what we will keep is obviously the transient tachypnea of newborn because it is born by a LSCS. Second could be chances of even a hyaline membrane disease because the baby is still preterm. Though the majority of the babies who are born more than 34 weeks will be lesser chance, but still it could be mild HMD which can occur in these babies. Remote possibility of infection can be there, but we should not jump in the practice by just looking at the one symptom of respiratory distress in the baby. And that too, you are showing an X-ray with the classical features of transient tachypnea of newborn with a hyperinflated lung fields with little features of pulmonary edema, and we have one fissure in the fissure prominence in the right lung, that is a pleural, suggestive of pleural effusion. So definitely we will not start any antibiotics in this baby at this point of time.
Okay, so I agree, but I will not add any further. But let us see the case progress. Increasing respiratory distress, grunting, started CPAP. Are you still brave not to start, Dr. Tejo?
Okay. Again, now, Dr. Vijayan, we discussed now what could be the possibilities in this baby. So the major possibilities in this baby is that we have the X-ray with us, which is showing only a transient tachypnea of newborn for us. Okay, but of course the baby has deteriorated in front of you. So what could be the possibilities in the when it deteriorates? Distress might have been due to has increased due to inadequate therapy of respiratory support also, or over therapy of respiratory support also. So first we should need to address what we have intervened and how the disease has changed. So I will immediately will not jump and start antibiotic, but I will evaluate based on these two aspects.
Okay, agree, totally agree. And people say that you are brave. More to the story. This baby after 6 hours admission now blow the pneumothorax, and now what you do?
So
And
obviously,
raised and settled, and oxygen requirement is coming down. Over to you.
so obviously the picture is clear here. The diagnosis only the pulmonary air leak syndrome, that is the pneumothorax, and you have intervened rightly with the intercostal drainage, and the baby has shown you the relief also. Okay, both for you and but for the baby also symptoms have reduced because the anxiety from your side has reduced, and for the baby also oxygen requirement has reduced. Okay, so I am definitely sure that this could be probably due to pulmonary air leak syndrome only. If you have done in aseptic precautions and properly, definitely there is no need for any prophylactic antibiotics in this case scenario. Okay.
Agree, totally agree. So what Dr. Teja Pratap is trying to say that there are clinical features of other conditions which mimic sepsis. If you identify and if you're confident, then no need to start. At the same time, if there's a detail, because it's a very usual, when you go back on the morning round and your resident say that, sir, baby has become sick, that's why I start antibiotic. But is the sickness is due to sepsis or something else? That's what Dr. Tejo nicely described to us. So no need to start a antibiotic. Is a definite non-infective condition is there. Okay. Now next question. 30-week preterm baby, 1 kilo, delivered because of maternal PAH, and there's no risk factors for sepsis. Received antenatal steroids, early respiratory distress, and started on CPAP. And this is the X-ray. Now, Dr. Sriram, would you or should we start antibiotics to this baby? Dr. Sriram.
Yeah. So good morning, everyone. So in this case scenario, this is a preterm, and he's almost like an extremely low birth weight baby. So delivered, the indication being maternal PIH, and the risk factors for sepsis was mentioned that it is not there. So what are the risk factors which are mentioned here? Preterm premature of rupture of membranes is not there, and no other risk factors like maternal fever is not there. So we presume that there is no maternal fever, no signs of chorioamnionitis in the mother, or urinary tract infection, or any other infection for that matter prior to delivery in the mother. So, and this baby after birth developed distress for which he was started on CPAP. And as you can see, this is a classical picture of HMD on the X-ray. So there is an air bronchogram, almost like a whiteout here in the lungs. So So there is no need. So when you have a clear-cut picture, just because babies, so the one risk factor in this baby for infection is prematurity, and the weight is almost like a ELBW baby. Even though he has these risk factors, but we know the reason for respiratory distress here is a classical RDS. So RDS is non-infective in nature. So for that reason, we can definitely withhold an antibiotic, look at the progress of the baby, how he is improving. So plan a surfactant, give surfactant, and then monitor the baby whether he is improving as per your plan. If such a scenario is happening, because the baby is in NICU and you are monitoring the sick baby, so you can wait for starting an antibiotic at this point of time.
Agree. But you actually reiterated what Dr. Tejo said, and you both trained in the same institute, I know. And but your junior doctor came to you and said, sir, white cell count is 4,000, platelet count is 1.2 lakhs, and it is just done because that usually normally routine bloods were done in the previous unit I worked. Now, would you start antibiotics now on this baby who was born preterm, RDS, and has low white cell count and low platelet count?
Yeah.
And also
so here we have a baby who is having this kind of a blood picture. So the whole, if you look at the, take it as a sepsis screen per se. So you have two parameters are positive in the sepsis screen. That is, you have a leukopenia as well as CRP just borderline positive, as well as the platelets are lower. So if the baby is clinically improving, so because you have given surfactant, you have given an adequate CPAP, and the baby is improving, so just based on these reports, you may not start antibiotic. The reason for this, because there are other reasons for this kind of a picture in this baby. If you remember the history, this baby was born to a mother who was having a pregnancy-induced hypertension, and these parameters can be explained by PIH itself. PIH is known to cause leukopenia. PIH is known to cause thrombocytopenia, and a borderline CRP of 10% doesn't mean anything. So even if you take the sepsis screen per se, the predictive value, the positive predictive value for what do you call this kind of a picture is very, very low. It's almost like 30%, not more than that. For the entire sepsis screen, if you take, the predictive ability of it for early onset sepsis especially is very low. It is only around 30%. That means you end up, if you want to give antibiotic just for this picture without in a clinically otherwise normal, clinically a baby who is not having sepsis, you end up treating almost 70% you unnecessarily give antibiotics. So for this reason, just looking at the blood picture doesn't warrant an antibiotic. But at the same time, you have to clinically monitor the baby very meticulously, ensure that he is improving, because if it's clearly a case of RDS, we expect a significant improvement after giving a surfactant. His FiO2 has to come down, his distress has to come down, provided you are giving an adequate CPAP, and the procedure of surfactant delivery to the lungs has been done in a complete asepsis manner. So if the baby is improving, then it is worthwhile waiting before you start an antibiotic at this point of time.
Yeah, totally agree, Dr. Sriram. This baby is getting better and you are planning for extubation. And you rightly said, don't treat the blood reports, treat the baby, and also see the reasons why these counts or the so-called inflammatory markers can be uh, abnormal because of the other conditions. In this condition, you already nicely explained to us, just to show you an example. And as the previous speaker said earlier in the CME, that don't stick on to just the inflammatory markers like CRP, procalcitonin in the blood count. See the baby. Dr. Murkis are also reiterated that once. Okay, and these are some of the, this literature is everywhere, you can search. So some of the guidelines to explain us, to help us when to start, when not to start. Definitely do not use inflammatory markers in asymptomatic babies. One of the common practice which people do is a preterm baby born by cesarean section due to maternal non-infectious conditions or placental insufficiency. People start antibiotics, not required. So, and I'm not going to read all that. Okay, I'll go to a third case scenario. A 35-week-old baby, 2.6 kilo, ruptured membranes for 36 hours. Mother did have fever of 101 degrees and baby developed tachypnea. So, Dr. Aparna, would you start antibiotics for this baby?
Thank you for the question, Dr. Vijayanand, and I also thank Dr. Murthy, Dr. Venkat, and the panel of IAP TCB for having me on this panel. So, yes, I think in this scenario, I'm probably the first panelist to say that we should probably start antibiotic in this given scenario. But let me try and explain an approach to the decision of use of antimicrobials in a case of suspected early onset sepsis. So essentially, there are two important factors. One is the neonate symptomatic. Now, having a symptomatic newborn, symptoms meaning newborns don't have symptoms, typically we are talking about signs. So respiratory, hemodynamic signs, feeding intolerance, hypotension. So all these which amount to significant signs which may clinically indicate sepsis, significantly increase the chances of the neonate having a risk of early onset sepsis per se. So a symptomatic neonate with risk factors would be an appropriate setting for starting an antibiotic, of course, after evaluation, after sending the diagnostic workup, including blood culture, and of course, in a symptomatic neonate with suspected early onset sepsis, a lumbar puncture. And then every effort must be taken to cut down the duration of antibiotic use in a neonate who subsequently becomes clinically well and cultures and labs are normal. I would also like to talk about two schools of approach, two schools of thought in an asymptomatic neonate who is suspected to have sepsis. So one is the scoring system, which is sort of popularly used in the PGA school of thought. And Dr. Saurabh Datta sir has done a lot of work, and even Dr. Sindhu alluded to the newer sepsis score of PGA, where intramural babies evaluated for early onset sepsis. 6 factors were clinical factors, maternal factors were found to significantly increase the risk of early onset sepsis, and these were scored based on their odds ratio as a score of 2, 3, or 6 based on the weightage of the odds ratio. So the two important risk factors which have a score of 6 among these are clinical chorioamnitis and multiple TB examination. Some studies have also spoke about foul-smelling liquor and extremely prolonged duration of rupture of membrane, more than 72 hours, as factors wherein if you have even one of these risk factors, the score becomes more than 6, and one would start antibiotics after sending a blood culture. Of course, if the neonate continues to remain asymptomatic and cultures come back sterile, you would stop antibiotics at 48 hours. Now, moving on, the other school of thought, which doesn't really look into the scoring, but looks into the baby's clinical evaluation and takes the assistance of laboratory evaluation, the sepsis screen. So this is a slide from Dr. Richard Paulin's guideline which was published in the American Academy of Pediatrics 2012. So here, we not only take into factor the risk factors, we also evaluate the baby clinically. If the baby remains clinically well and the risk factors did not include something like chorioamnitis, which carries a higher weightage, one you could just observe the baby, and until 48 hours, if the baby remains well, we need not evaluate or start antibiotics at all. But if the risk factors included chorioamnitis, the neonate would be subjected to a short course of antibiotic with or without evaluation with the blood counts and CRP done at 6 to 12 hours. And again, if the neonate remains well, you would stop antibiotics. If the neonate requires or develops clinical symptoms, then the neonate would be treated as in clinical sepsis with a complete evaluation, including lumbar puncture. So I hope it answers the question. So we take a decision based on the symptoms of the neonate, and number 2, the extent of the severity of the risk factors, either decided based on a scoring system or based on the number of risk factors coupled with or without laboratory evaluation performed within 6 to 12 hours of age. The importance of careful observation of clinical symptoms in the neonate cannot be underemphasized in any of these situations.
Thank you, Dr. Aparna. Basically, what you're trying to tell us is, to rephrase it, it's important to pick up those babies who are very high risk of developing sepsis. To do that, 2 things which may help us is one, the clinical scoring and a laboratory data. So putting them together, at the end of the day, the most key thing is the baby. So how is the baby progressing? So I remember as a postgraduate even giving a 3 dose of IM injection for all the babies who use prolonged rupture of membranes. I don't think that is recommended anymore. I'm going to stop it there. So I have another question for you. You are the first one to decide to start the antibiotics for the babies. Okay, then you need to tell me, you need to tell us which antibiotic, how do you decide the first line, second line antibiotics in any neonatal unit for that matter. In other words, what I'm essentially asking is, how do I develop an antibiotic protocol from my unit?
Right, very important question. So typically a first line antibiotic in neonatal unit would be a combination of a basic penicillin and an aminoglycoside. Now taking into consideration that this combination should typically cover at least 60 to 70% of the common organisms grown in that unit. So obviously this decision would differ unit to unit based on the spectrum of organisms identified in that unit. So whether it is gram negative, like in most Indian units, as we saw in the Dennis data, and whether it is gram positive, which would be the setting in most of the high income countries, like in the Western world, the basic combination should include a antibiotic which covers gram positive. So typically a combination of a semi-synthetic penicillin and an aminoglycoside, which would cover both gram positives and gram negatives, is what we are looking in most of our units, because we all know that 2/3 of the organisms identified in our neonatal units are gram negative. Now, this also should include the consideration that of the antimicrobial susceptibility pattern. So not only gram positive, gram negative coverage, but also the common antimicrobial susceptibility pattern. So you showed us the data from the Dennis trial where nearly 80 to 90% of gram negatives identified in the isolates grown in the study were already resistant to the common antibiotics. So obviously, an oversimplification or the usage of something like the WHO recommended ampicillin gentamicin might not be appropriate, knowing that 80% of the bugs are already multi-drug resistant, especially in an extramural unit. So to simplify this, the first line combination in an intramural unit, where you know that most of the bugs are sensitive, and considering that the profile of organisms is a combination of gram negative and gram positive, a combination of a basic penicillin and a basic aminoglycoside would suffice, with the consideration that this should cover almost 60% of the commonly grown organisms in the unit. So a combination of ampicillin, gentamicin, combination of, in a Western unit, something like flucloxacillin and gentamicin, remembering that staphylococcus is one of the commonest bugs, might be appropriate if you think that the proportion of multi-drug resistant bugs is likely to be low. However, if one is working in an outborn unit where more than 80% of the organisms would already be multi-drug resistant, this combination may not suffice, and one has to look into the common, the spectrum of antimicrobial resistance pattern and make a choice which would cover nearly 60% of the organisms grown. The second line typically would cover, something like 90% of the organisms grown in the unit commonly. So typically beta-lactamase producing organisms also must be covered. So something like piperacillin tazobactam with aminoglycoside would be more appropriate in our kind of setting. And of course, a third line typically should also cover the ESBL producing organisms.
Thank you. But what you're trying to say is the Western guideline might not necessarily apply to us. You need to find your own unit guidelines based on what is your antibiogram and sensitivity. Dr. Tejo, I just want to ask one question here. I understand your unit uses a single aminoglycoside to start with as a first line. Is that right? Can you just talk about a couple of minutes?
What Aparna told right now also, based on these three parameters, we are looking at it. One is that common organism in your unit. Second one is the sensitivity pattern and surveillance swabs. So what idea of giving single dose mono antibiotic therapy is to narrow the spectrum. We don't want to use the very extended spectrum of antibiotics in the beginning. And still our organisms are mostly like around 70% of the organisms are susceptible to amikacin. We initially thought that whether we have to do amikacin gentamicin rotation, but still our amikacin is holding very good. So that's the reason why we are still continuing with the amikacin therapy.
Excellent. So excellent. That's a beautiful example of knowing your unit, knowing your bugs, doing the right thing with the minimal antibiotic with the maximum benefit. But another thing is keep reviewing it. That's already you alluded that to as well. And the third case, when will you stop antibiotic? I think this is for Kalyan. I by mistake I kept Aparna there. So Kalyan, now this baby Aparna started antibiotic, but she went on holiday. Now you came to duty and CBP, CRP are normal and tachypnea is resolved. Baby is doing well. What do you say, Kalyan?
Sir, if the blood culture comes, we started antibiotics based on the fact that there was extreme risk factor and then the baby was symptomatic.
Correct.
Once the symptoms settle and the blood culture comes back normal, then the moment we know the blood culture is not growing anything, I think we should stop the antibiotics straight away. In our unit, our microbiologist gets back to us by 36 hours and then we generally stop antibiotics by that time.
So, well, you said straight away, I just want a clarification here. Would you stop at 36 hours, 48 hours, or 72 hours? Baby is otherwise absolutely fine.
Sir, I mean, I worked in a spectrum of NICUs, so it depends on how well we communicate with our microbiology teams. So if the team is confident in getting back to us at the earliest, I think we should stop the antibiotic at that point. Evening or morning doesn't really matter. Rounds or no rounds doesn't really matter. We should stop the moment we are done.
Okay, so I totally agree. Earliest possible opportunity to stop, but for early onset sepsis, there's a clear evidence. The Oxford unit, they stop at 36 hours. Late onset can be tricky because the bugs can be, especially when you are dealing with the fungus infection, they can be delayed positive culture. You need to again put clinical correlation and see if the baby is well. And earliest opportunity, you should stop the antibiotics. And I think this is for you as well, Kalyan. 20-day-old preterm, 29-weeker, 1.2 kilo. Sorry, bit long story here. Spontaneous vaginal delivery, distress, CPAP, treated for sepsis. But unfortunately, culture is not done. But I think they should listen to Murki sir. There is no excuse not to do the culture. And treated with piptas, meropenem, vancomycin. 3 of antibiotics are going on, but they are small unit outside Hyderabad. Persistent thrombocytopenia, serious sepsis, they thought they will send to you. And baby came to you on CPAP 6 centimeters, FiO2 30%, initial septic screen in your unit, platelets 4,000, white cell count is 25,000, and CRP 156. There are chest X-ray changes. I just want your thoughts about the current antibiotics which baby is on. What would you start, and what do you think about this combination of antibiotics?
So there are 3 points here. Like first, should there be antibiotics? So definitely yes. The baby clearly looks septic. The baby has all the clinical features and lab supporting evidence of sepsis. Unfortunately, there is no blood culture. I would also pay attention to the septic pattern if they provide me the information with, like how was CRP before and when was it last done, and then that will give me some more clues to it. Looking at the combination of antibiotics that are there, the baby was on piptas and then meropenem and then vancomycin. This we see very often. I mean, it's not uncommon for most of us. And very often this happens because there is no stop guideline for antibiotics in the centers. Like this one classic example of where there's an opportunity to improve as well, but that we'll talk later. So first question is, when you have a group of antibiotics, we should look at the spectrum they're covering. If the spectrum is overlapping, then probably there's no role for the previous antibiotic. So in this particular scenario, the piperacillin, tazobactam, and meropenem, there's a lot of overlap there, and we should fine tune that. 1, 2. Other common examples of this kind of combinations are meropenem, metronidazole, already ampiclox, and then again on vancomycin and with ticoplanin or linezolid. We do see this kind of combination of antibiotics that keep coming to our ICUs. So what do we do if such a baby presents to us? Yes, we need to fine tune the antibiotics. And what would I start? By the unit protocol, like how Madam has clearly said, we should have the protocols clear and laid down based on what we see. For an outbound baby, clearly septic and on multiple antibiotics, we move on to the second line antibiotic of what we would use. That would be in this particular scenario with thrombocytopenia. I would probably start the baby on meropenem and fluconazole. There is a very interesting observation we have made back when in Bangalore, that we did something called antibiotic mapping. So there's a good potential. There is a recent paper that came out as far as asphyxia is concerned, but I think there is a good potential even for antibiotics. If we are working in a tertiary care unit and we keep constantly getting babies from well-known centers, then probably we can fine-tune the antibiotic to the known culture patterns of those particular centers. So I will share a small story, very quick story on this thing. So we had a baby who came to us from Chitradurga back when I was working in Bangalore Rainbow. The baby came with similar scenario, thrombocytopenia, high CRP. We started on fluconazole, meropenem in that scenario as well. The baby rapidly crashed and expired that night. Right? And this particular unit we knew had Acinetobacter sensitive only to cholesterol. So having such an understanding of where your baby comes from and then what is the nature of culture in that pattern probably has a very big role. And in the wide variety of practices we do with a lot of extramural babies, I think this has a very potential role in the future.
Okay, thank you, Kalyan. I think what you're trying to say is think about the spectrum it covers rather than just adding one after the other. And unfortunately, the blood culture was not taken here. That would have helped us as well. And the other thing is the example you gave, a little bit be cautious and careful, where it is important to know where the referring unit bugs are coming from. And you can always go back and give them a feedback, but be cautious though, and how you deal with them, what you say, and how you deal with them. And and also knowing that will also help. And this baby blood culture, you did blood culture, your team did blood culture, and came as Klebsiella pneumonia. Looks like very sensitive bug. What should we do now?
Very fortunate. We got a culture positive despite exposure to multiple antibiotics. And you should definitely look at straight away downgrading antibiotic. I know we are already on meropenem. I know this bug is sensitive to meropenem, but there is no reason why I should still be with meropenem. So probably I would bring it on straight away to our second line in our unit, that is piperacillin tazobactam, and probably be very happy with it.
Yeah, before you think that one, I absolutely agree, you de-escalate and downgrade, but also see the extent of the infection. Is the CNS involved or not? Is the antibiotic I am giving is covering or not? That the one thought we should keep in mind. But absolutely agree. Even if the baby is started on I or escalate to I level, the moment you know that there's a sensitive bug, you change your antibiotic accordingly as based on your culture and sensitivity reports. And okay, fine. So case 5, term baby, shoulder dystocia, usual story, fetal distress and difficult transition and HIE. I'm not going to read everything. And this baby ended up like this in our own Indian Mira cradle, cooling. And now, question to you, Dr. Tejo, would you start antibiotic for this baby who is admitted, who is very sick and on HIE, with HIE, sorry.
Okay, yeah. So again, previous first case was basically you had a more respiratory compromise. Here you are having the compromise on the alert status and also on the hemodynamic status of the baby. So again, these two also might not be due to sepsis alone. There are a lot of other conditions which can cause both the encephalopathy and shock in the children. So it's also a clear-cut case where you have the setting to have the baby having severe perinatal asphyxia, which can cause a multi-organ dysfunction without even infection. So definitely we will not start antibiotic at this go, but definitely we will be watchful whether there is any worsening or anything. We will go with the other lab support to look into it.
Yeah, absolutely agree. If the baby is sick for non-infective reason, don't start as we discussed. However sick, if there's explanation. Can you tell us, Dr. Tejo, a few more conditions where commonly the apprehension of the pediatrician or the clinician like us would tend to start antibiotics but not required?
So this will happen because there is a lot of overlapping symptomatology in between the conditions in the neonate. Okay. So as I told in the beginning, just before also, there are three symptoms which all of us will be very worried. One is respiratory distress and apnea. Second one is the encephalopathy. Third one is the shock symptoms. So for respiratory distress and apneas could be due to any other reasons also, something like a TTNB, meconium aspiration syndrome, and other symptomatology. Second could be encephalopathy. Again, it could be due to metabolic or a CNS cause like what we had in asphyxia or a non-convulsive status. This could also be the possibility here. Okay. Third one is a shock. Shock again could be due to hypothermia or your metabolic reasons like inborn error of metabolism, or due to cardiac condition itself because of some congenital anomaly in these cases. So in all these conditions, there is no role for straightaway antibiotics. Other two conditions where we'll be more worried is that simple feed intolerance and the jaundice, significant jaundice like severe hyperbilinemia, whether I am missing. Not routinely all these babies will have a high chances of infection. You have to look at the symptomatology. If you have any features suggestive of sepsis, walk up the baby. If you have symptoms supported by your lab diagnosis, then only you need to go with the antibiotics in those cases also.
Absolutely. There's a little bit of list over there. Thank you very much for that. Can I ask the Murki sir and Bhaskar sir another 10-15 minutes, sir?
Okay, no problem, Dr. Vijayana, no problem.
So case number 6, thank you, sir. 28-week-old baby, 1 kilo, now 3-week-old, feed intolerance intermittently. PICC line is in situ. And presented with recurrent apnea, circulatory shock, as Dr. Teja was saying just now, intubated, ventilated, very busy morning, and started on piptaz and fluconazole. And your platelet count came as 24,000, white cell count 33,000, CRP is very high, 150. And blood culture on day 3, growing candida. Okay. Now, question to Kalyan again. I think Kalyan or Aparna, one of you can say this. I think that your questions are mixed up. If baby would have received fungal prophylaxis, could we have prevented this fungal sepsis? I think I'm supposed to be Dr. Aparna, is that right? Yeah, sorry.
Okay, so yes, role of fungal prophylaxis in ELBW neonates has been controversial. We have had a lot of data and meta-analysis from the Cochrane. So essentially, the carry-home message is, yes, it may be useful in units where the incidence, the baseline incidence of fungal sepsis is say high. A typical incidence is anything more than 10%. There, giving a routine fluconazole antifungal prophylaxis in ELBW neonates will reduce the incidence of invasive fungal sepsis, like this, a baby developing candidemia in the 3rd week, 4th week. May come down, however, it doesn't change the incidence of mortality. So you could say some benefit in units which have high baseline risk of fungal sepsis. But again, the role of prophylactic antifungal is like, mopping up the problem, or just, it's not the permanent solution. The more important solution would be to emphasize on, infection preventive measures and trying to find out why is there a high incidence of fungal sepsis.
Yeah.
Now, in units where this is not the case, even among babies less than 750 grams, giving routine antifungal prophylaxis doesn't really change the incidence of invasive fungal sepsis or mortality. So ultimately, this is a very unit-specific decision. So we cannot say yes or no without understanding the unit dynamics. So if your baseline incidence of fungal sepsis is extremely low, which means that you are doing your infection preventive control measures very well, you may have a very lower incidence of outbound unit admissions. The rate of prolonged ventilation or prolonged use of broad spectrum antibiotics or prolonged TPN might be low. Then your unit doesn't really need antifungal prophylaxis.
Agree. I totally agree. It depends upon how high your fungal sepsis rate is, and provided provided you got the data, and the units in Europe, especially UK, where the certain units of fungal sepsis is very low, they don't use routinely. In US units, there is a high rate, they use it. And one of the word of caution for all of us here is, increasingly we are seeing multi-drug resistant fungal sepsis. The typical example is Candida auris. So not only for prophylaxis use, but also think of when you are using therapeutic use, whether are you using the right time for the right reason, the antifungal, not only antibiotic. Just to be aware, Candida auris is probably going to be a problem for us. It's already started, might be a problem for everywhere. In the last decade, it is emerging. So now we talked about this. Now, Dr. Sriram, 10-week-old baby born 28 weeks, who is a feeder and grower, posted for inguinal surgery. Pediatric surgical resident who just joined, prescribed antibiotic for 48 hours. And you came and look at the drug chart. And now, what do you say? Would you follow the plan or change the plan? And just before you answer, I want to show in the previous unit, she sees this sort of babies where this is the result. That's why she's worried. The surgical site infection becomes so bad. So she thought giving antibiotics for this baby would be beneficial. Over to you, Dr. Sriram.
Yeah. So if it is for an inguinal surgery, that means inguinal hernia, then the ideal strategy, because it's a clean surgery, there is no evidence of any obstruction. I mean, there is no gangrene or any infection in the bowel. In such a scenario, there is no need to give antibiotics for such a long duration. What is recommended is to give 1 hour before surgery, baby will need an antibiotic. So that has to be given before 1 hour before the incision. The baby has to be given the antibiotic, and then post-operatively, it need to be continued for 24 hours. That is more than enough. Because during surgery, we presume that all the precautions will be taken for preventing infection in the surgical theater. So that if everything is taken care of, then it is very well shown that the incidence of surgical site infections is not more if you restrict the antibiotic to just 1 dose prior to surgery, 1 hour prior to surgery, and subsequent dosage for 24 hours. That is more than enough. If it is for a clean surgery, like a non-infective conditions. But if the surgery is being done for, say, example, a necrotizing enterocolitis or for a colorectal problems like, say, Hirschsprung's disease, then you may need to continue for a little bit longer duration for probably 48 hours or 72 hours. But in most of the scenarios, then the post-operative antibiotics need not be given for more than 72 hours. But if it is for an infective scenario like NEC or an abscess, then you may have to continue depending on the cultures and the infection till the infection is completely cleared. So, but in all other scenarios, if it's an elective surgery, especially like inguinal hernia, 24 hours is more than enough.
Absolutely. I mean, what you're trying to tell, just to rephrase, is the surgery, is the baby well, or is surgery for baby, sick baby with sepsis, and is the surgery for the septic condition. So based on that, your antibiotic, and majority of time, a single dose skin to knife within 1 hour, and then followed by maximum 24 would be suffice, which is what the IDSA, Infectious Disease Society of American guidelines says. Thank you very much, Dr. Sriram. And the other question now, 34-week infant born to primary with severe PIH, no risk factors for infection, well baby, and junior doctor, he did routine bloods. So he used to do. So white cell count is 23,000, CRP 18. And I think this is for Dr. Aparna. What is the value and role of inflammatory markers initiating or discontinuing antibiotic therapy? But I'll just say, just keep it a bit brief for Dr. Aparna in lieu of time, sorry.
Sure. So, value of inflammatory markers in initiating sepsis, I would say that the value is relatively small, considering the fact that the clinical presentation of the baby is the most important factor. So the dictum is never treat CRP or procalcitonin, always treat the baby. If the neonate is significantly sick, you may decide to initiate antibiotics irrespective of CRP. If the neonate is well and CRP is positive, as Dr. Sindhu already told us, the positive predictive value of CRP or a screen in general is only 20 to 30%. So do not initiate antibiotics in a well baby with a positive CRP. Yeah. Now, coming to the value of inflammatory markers and discontinuing antibiotic therapy, I would say CRP is probably more meaningful in this situation, especially after 24 hours of postnatal age. 2 negative CRP separated by 12 to 24 hours give us 99% confidence that the baby is not having sepsis. So in a baby who is on antibiotics, once you feel that you do a CRP and it is negative, then you are fairly certain that this baby does not require any further duration of antimicrobial. However, we do not routinely repeat CRP also in a baby whom we are treating for infection. If the baby is clinically well, you can stop antibiotics based on the clinical discretion. However, if some signs and symptoms of sepsis seem to be lingering, you can take the assistance of inflammatory markers. If markers are negative, then you are more confident in stopping antibiotics. If markers are positive, you evaluate the baby for signs of occult infection.
Yeah, and also as Dr. Rishikesh Thackeray said, and think of non-bacterial sepsis, and also think of the conditions which mimic sepsis. One of the classical examples is cow's milk protein allergy, where your CRP is going up, baby is well, people keep on giving the antibiotics. And I will not do any further comment there. Well, Dr. Sriram, well, we have so much of knowledge. We know that antibiotics are not necessarily good. But we struggle not to stick on to these guidelines. Why there is a gap this between knowing and doing syndrome? Why? Can you help us to understand why we are not able to do that?
Yeah. So here there is a gap in from the translation of knowledge to bedside. This is because of the very challenging scenarios which we all face in neonates, and we all know that everyone knows that sepsis is the commonest disease which we all encounter. So that could be one reason. And the clinical symptom, there is always an overlap. I mean, almost all illnesses in the neonate present with similar clinical signs and symptoms. So differentiating, there are no specific signs or symptoms which will differentiate sepsis from a non-septic illness. So that is another thing, because your predictive ability of these signs and symptoms for sepsis is very poor. And if you look at the inflammatory marker, just like Dr. Aparna has just told us, they tend to be positive even in non-sepsis as well as in sepsis. So their predictive ability is also low. And the definitive markers of sepsis, like culture, where it is considered as a gold standard, the turnaround time is not very early. It at least takes 48 hours for the reports to come, and then decide whether the baby is having a sepsis-like illness or a non-septic-like illness. So because of all these things, there is definitely the healthcare person may not follow the same guidelines, even though there are well-established guidelines, and there are gaps in these things. But still, even though there are gaps, there are challenges, but still it is quite possible to restrict the use of antibiotics, as we have been discussing in several case scenarios till now. So we can narrow our decisions, we can look at the baby, examine them properly, take the history into consideration, take the clinical picture into consideration as a whole and the lab parameters, and then decide whether the baby really needs an antibiotic. Even if we start an antibiotic, the ideal thing would be to send a culture and then stop an antibiotic. So that is what, as early as possible. I think there we have to, we need not continue antibiotics. So that's one thing we have to take care.
Agree. So, I mean, every clinician wants to do the best. So nobody wants to just to add the antibiotic just like that. But there are the challenges which Dr. Sriram nicely described it to us. But Kalyan, how do we optimize? We know that we need to do the appropriate use. We don't want to do misuse or abuse. How can they achieve that? Kalyan, can you say a few words on that?
Yes, sir. I mean, I'll keep it very brief. Most of us, what we discussed so far, and we should only use it as limited as possible. There's a single word stewardship program. Every single stakeholder in the hospital should be made part of and should be given a power that is enough for their level to. I'm talking about resident, nurse, pharmacy dispensary group, the consultants. All these people can act at various levels to decrease the number of antibiotics that we can use for a baby. So, like sir rightly pointed out, sending appropriate anti-inflammatory inflammatory markers, and then starting antibiotics only when we think the baby deserves, stopping them where it is not needed, de-escalating at the earliest, and as a team marching forward so that we don't tend to deprive a baby of an antibiotic where the antibiotic is needed. At the same time, we don't overuse a single dose of antibiotic. Keeping a close count on what all antibiotics, how many times, whatever we are doing will guide us in understanding how well we performed in the previous quarter versus the next quarter per patient.
Okay. So essentially you are alluding that we should follow antibiotic stewardship program. Anybody can see these 10 points, key points came from International Society for Chemotherapy, and it is freely available on the internet. Now the question to Dr. Tejo, again, we know how to do it, but how can I implement antibiotic stewardship program?
As Kalyan told just now that the key strategy should be to prevent resistance is one thing. At the same time, toxicity also can be reduced by.
Sorry to interrupt, Tejo. Vijay, can we close in another 1 minute?
2 minutes, sir. Okay. So, okay, then if that is the case, I'll ask a different question to, okay, building the team for like anything, infection control. And what I'm going to do is, again, our small units don't necessarily think that they have a team. They do have a team in the form of pediatrician, pharmacist, and nurse. And most important document or the information we want to share, I want Tejo to talk about it, the aware the classification of antibiotics. And after that, we'll finish, sir. I promise I will finish after that.
So this is one of the important document released by the WHO last year on classifying antibiotics into 3 categories. First one is the accessible antibiotics. Second one is the watch. You have to keep a watch group of antibiotics. And third one is the reserve antibiotic. In the access group of antibiotics, like simple amoxicillin and these things can be there, like trimethoprim with routinely used to be there in the, even at the PHC level also they have to be there. In the watch group are a little reserved drugs, which has to be taken the decision by an expert, or at least a senior person has to take the decision. And then reserve group, actually a committee has to decide that whether those antibiotics have to be given to that child or not. Okay. These are freely available in the internet now. I think we can share the data.
Yeah. Okay. And it's freely available. There's an excellent sheet. But again, I'm going to stop it there. The metrics of antibiotic use, like you monitoring your VAP and those. So shall I take a take-home message from one message from each panel, or shall I stop, sir, Murki sir?
Yeah, I think you can end with that.
Yeah. So take-home message from Dr. Sriram. One take-home message.
Use to send a culture prior to you starting an antibiotic. So don't start an antibiotic without sending a blood culture. So that is very, very important.
Dr. Kalyan.
Sir, I mean, having a very guided antibiotic policy for your own unit, because you know your unit best.
Excellent. Dr. Aparna.
Avoid excessive reliance on non-specific inflammatory markers like CRP to initiate antibiotics. Never initiate antibiotics in a well neonate with positive CRP.
Okay, Dr. Tejo.
Okay, audit your policy time to time, and then restrict the usage of antibiotics as much as possible. At the same time, improve your aseptic practices. This is the main thing. It will give you a lot of confidence to stop antibiotics. That's what I can say.
Okay, after listening to from all my panelists, there's nothing more to say from my side. All I would say is decrease the gap between knowing and doing. Do the translation as Murki sir always says, and practice whatever we are trying to learn from this workshop. I'm going to end on that. Be smart in using antibiotics. Thank you very much once again to my panelists. They have been great, as you see, and also the organizing committee, Dr. Murki sir and Bhaskar sir and Reddy sir. Thank you.
Thank you. Thank you.
So thank you everyone, and my special thanks to IAPTCB, Dr. Bhaskar, Dr. C.N. Reddy, Sridhar, and also special thanks to some of the seniors who have been part of this program, Dr. Subramaniam sir, Anand, Dr. Anand, and I saw Dr. Alimelu being there. So I think it's a wonderful program, and I think all the faculty and the delegates enjoyed the maximum. We can still see the attendance of about 60 people still present. So I think that itself marks the success of the program. Over to you, Dr. Bhaskar sir and Dr. C.N. Reddy sir.
I'll stop sharing.
Thank you, Dr. Srinivas. As expected, it was an excellent seminar. It is really befitting to the last seminar of our IAP-TCB for the year 2020. Amazingly, more than 140 persons sat for nearly 240 minutes. Most of them sat for 240 minutes, but it passed just like 30 minutes. We had thoroughly enjoyed because all of you had given the messages so well, particularly the panel discussion led by the cool, cheerful gentleman, Dr. Vijayanand Reddy, Vijayanand, and the messages given by the all panelists were really not at all overlapping. Each one of them was so important. I'm sure it was not a pre-edited or pre-planned, but it was a spontaneous messages, wonderful messages. And I thank Dr. Rajendra Prasad for giving very good Indian statistics of neonatal sepsis, and excellent presentation by Dr. Venkat Reddy with graphics, good graphics and basics of immunity in neonates. Dr. Sindhu gave very good insights into the diagnosis of sepsis and dwelled so well on the importance of culture, to develop the culture of doing blood cultures by all the healthcare professionals. And Dr. Venkat dwelled on hemodynamic instabilities and other appropriate supportive care and with antibiotic stewardship. Dr. Rishikesh, by virtue of his wisdom, he had presented excellent case scenarios, which he had said, eyes don't see what brain doesn't know, and mind is like a parachute. A good caption. It has a lot of impact. Dr. Murki, he was really excellent, expert in making the closing expert remarks on each presentation, and his presentation itself was a mesmerizing and music to ears. Thank you, Dr. Srinivas, and I thank all the faculty members and particularly Dr. Srinivas Murk for taking up this Herculean task. He did a wonderful job as very much expected. And special thanks to our seniors, our colleagues for really supporting us by participating in large number. With these few remarks, I request our President, Dr. C.N. Reddy, to make the concluding remarks. Over to Dr. C.N. Reddy, sir. Unmute, Dr. C.N. Reddy, unmute yourself. Unmute, Dr. C.N. Reddy.
Thank you, Dr. Bhaskar. It is already late. I will finish within 1 or 2 minutes. Thank you, Dr. Srinivas, for coordinating this excellent program. Very much useful. And we enjoyed a lot. It was a good learning experience by all of us. And really, I thank you for organizing this module, very useful module. And I also thank today's moderator, Dr. Vijayanand, and Dr. Sriram, Dr. Aparna, Dr. Tejo Pratap, Dr. Kalyan Chakravarti, Dr. Rajendra Prasad, Dr. Venkat Reddy, Kallam, Dr. Sindhu Shiva Nandan, and Dr. Venkat Verdalli, Dr. Rishikesh Thakre. Thank you very much for designing this program, and we have really enjoyed this program. And I thank seniors who has participated, Dr. Tilak sir, Dr. Ishwarachari sir, Dr. Anand sir, Dr. Subramaniam sir, Dr. Rangay sir, Dr. Venkateshwar Rao, Dr. Bhaskar Reddy, and so many seniors, they have participated. And I thank all the participants who have really enjoyed this topic. And thank you very much, one and all. And also I thank, this is the last program, I thank our committed Secretary, Honorable Secretary General of IAPTCB, Dr. Sunkoj Bhaskar. He has taken a lot of pains to give this much academic inputs in the year 2020. And I also thank Dr. Ranganath Garu, past President, Dr. Arjun, President-elect, Dr. Pavan, Dr. Sridhar, Dr. Suchitra, Dr. Lakshman, Dr. Vaidyam, Dr. Lalu Prasad, and Dr. Ajay Mohan for coordinating, cooperating, and for all these programs. Thank you, one and all. Namaste to all.
Thank you. Thank you.